We're at a point where, you know, it's going to be really hard to solve the workforce shortage by producing more of the workforce because it takes a really long time. For example, to produce a doctor, it takes 7 to 10 years. So even if you wanted to ramp up and produce thousands more in the U.S., you would you're looking at 10 years before that actually really happens, right? And so the pressures on the system to meet these these demands for convenience, for not waiting as long, and just to get people basic care, make it so that the solutions are going to have to be more than just trying to create more workers and trying to create more doctors.
Hello, and welcome to the International Business Today podcast. I'm Professor Ravi Sarathi, and in this IBT podcast, we seek to discuss important international business issues that are relevant to academics, practitioners, and students. My guest today is Professor Timothy Hoff, Professor of Management, Healthcare Systems, and Healthcare Policy. He's also Associate Fellow at the Green Templeton College at Oxford University. Before coming to academia, he worked in hospital administration and as a healthcare consultant. He specializes in emerging trends and innovations in the healthcare marketplace, particularly on the U.S. healthcare system, its current state, and future evolution. He's researched and published books and scholarly studies on the healthcare workforce, physician behavior, healthcare change and innovation, and the patient experience. His most recent book is Searching for the Family Doctor, Primary Care on the Brink, published by Johns Hopkins in 2022. He's published 3 other scholarly books, over 80 peer-reviewed journal articles, and he's received numerous awards for his research. He's widely quoted in the media, and he gives frequent talks to academics, policymakers, industry executives, and healthcare professionals. He's the faculty director for the undergraduate healthcare management and consulting concentration at the mckim School of Business, and he's also active in executive education, management consulting for healthcare organizations. Tim, welcome to our podcast series.
Thank you. It's good to be here.
Great. Let us start, given your vast experience with U.S. healthcare, let's start with U.S. healthcare. What are the main strengths of the U.S. healthcare system and some of the central problems that it's facing now and will continue to face over the next several years?
Our health system has always been known, I think, for its high-tech, innovative aspects, particularly around specialty care. The U.S. healthcare system is extremely good at what we would call high-level specialty care and medical innovation that revolves around that. And a lot of that has helped extend people's lifespans, has helped people manage their illnesses better through the course of their lifespan. So we're extremely good, I think, on the innovation front as it applies to high-cost care. And therein lies part of the problem for the U.S. health system in terms of that kind of innovation has tended to drive up costs in the system. The issues now, though, that are facing not only the U.S. health system but other international health systems really are ones of lowering the cost of care, finding innovation that actually brings down the cost curve, the inflation curve. And to that end, that means the U.S. health system needs to get better at primary care, prevention, keeping people healthy from the beginning, from the early stages of their life. And that's something that our system in the U.S. has not paid enough attention to over time, has not invested enough in. And so that, coupled with the need to serve more and more demand, because with people living longer, again, not just here but in other countries, and also with giving people greater access to health insurance over the past decade in this country, we've created a crisis in terms of not having enough outlets to provide people with the kinds of health care that they now want and need because they have the ability to access it.
So what you're really saying is the U.S. healthcare system is very good for extreme edge cases, but not so good at the middle, the vast middle that's increasing in size.
Yeah, and it's very good. You read the cases about, the ability to just do high-level surgical procedures, innovations in the pharmaceutical space, breakthrough drugs for things like cancer treatment. And all that's fantastic. And it has helped in terms of, like I said, people living longer, people living higher quality of lives. But it's really on the low-tech part of medical care and patient care that the system really has not delivered the way it should.
So, Tim, you have touched on the healthcare system becoming less physician-centric, which I assume means less reliance on primary care doctors, and instead moving to digital medicine. And then there's also the point you've raised about more retail-oriented companies like Amazon are coming into the healthcare space who do not use physicians and perhaps don't want to use physicians. Do you want to elaborate on this idea of less physician-centric and more retail? What does that mean?
Sure. Well, it's really linked to the problem we just discussed, right, which is this incredible access issue and the demand for timelier care, the demand for cheaper, less costly care, right? The demand for convenient care. I mean, this is what patients in the U.S. want more of. We see it in surveys. We see it, in how they talk about their health care. And so there simply aren't enough, for example, in primary care. There aren't enough primary care doctors to meet the kinds of demands for, visits, for timely visits, for convenient visits. And so you have these companies now, retail-oriented companies, I call them, the CVS Healths, Walgreens, Amazons, who are coming into the primary care space and saying, look, we can create a model that delivers faster care, delivers care that's more efficient, delivers care that's lower cost. But the doctor in that workflow and in that type of care has to be de-emphasized somewhat because the doctor is a very expensive part of a patient care workflow, so that would drive costs up. And the doctor is somewhat perhaps more inefficient, at least according to retail thinking at times, than using more standardized solutions that might involve, for example, digital technology that could move care quicker. Now, this only relates really to a certain type of care. The physicians aren't going to be put out of business, but there's certainly a threat to physicians being de-emphasized more in these models of care that need to move faster and need to be cheaper.
So really, this is the workforce question. Physicians are part of the workforce, and companies like Amazon want to change the composition of that workforce. And so there's some workforce implications, not just for now, but for the future, what kinds of workforce maybe we need. But also I imagine this creates a tremendous amount of mental health problems and stress for the workers in the healthcare industry, given the kind of pressure that's coming for productivity. So do you want to talk about that?
Yeah, absolutely. This is an area that I've studied a lot, burnout, wellness. We have a crisis, not only in the physician workforce and not only in the U.S. health system, but in, the U.K. where I go over to, same issue, nurses, support personnel. It was exacerbated by the pandemic, where, you had healthcare workers who felt unappreciated by their employers and thrown into situations that, they considered dangerous or considered above and beyond what they were, trained to do. And so with all this demand and all this, focus on trying to get people into care, whatever way we can, it's put tremendous strain on a workforce that doesn't have enough workers and a workforce that, is fairly burned out in a lot of ways. And so what needs to change is really how patient care is delivered across the board. It needs to be reinvented for the worker, whether it's the physician, the medical assistant, or the nurse. So this, retail-oriented companies, tech companies, they feel they have solutions that will help actually the workforce feel better about the work they do, make their work easier, make their ability to serve more patients better, but also not put them under more strain. And so we're in this moment where you have a lot of narratives that everybody's putting out there. We don't know yet which narratives are actually true or not, but the workforce is definitely going to be at the center of, I think, a lot of experimentation over the next several years in terms of redesigning patient care and what that actually means for the work that doctors, nurses, others do.
Mm-hmm. Now, from my own personal experience, shortages seem to be prevalent at the doctor level, at the physician level in healthcare, trying to see a dermatologist or a neurologist or even physical therapy. Almost anything, it seems nowadays, you have to be willing to wait for some weeks. So what is your take on this workforce shortage? Is this going to be alleviated or is it going to be exacerbated?
Yeah, it's a huge issue. It's in specialty care. It's in support types of care like physical therapy, imaging, primary care. We're at a point where, it's going to be really hard to solve the workforce shortage by producing more of the workforce because it takes a really long time. For example, to produce a doctor, it takes 7 to 10 years. So even if you wanted to ramp up and produce thousands more in the U.S., you would you're looking at 10 years before that actually really happens, right? And so the pressures on the system to meet these demands for convenience, for not waiting as long, and just to get people basic care, make it so that the solutions are going to have to be more than just trying to create more workers and trying to create more doctors. And the reality is, even if we wanted to create, for example, more doctors, medical schools, have constrained the supply of doctors and for a long time, for example, in the United States on, basically by design. And so you would have to really deal with a lot of upstream issues to open the spigots up to produce more of each kind of worker.
So it's also an institutional question. How are the current healthcare institutions, not just the physicians and the nurses, the workforce, but also the institutions surrounding them that will have to change or react in some new ways?
That's right. For example, part of the reason U.S. medical schools constrained how many doctors get produced in a field like dermatology or orthopedics, right, is because by doing that, it keeps those fields prestigious. It keeps them in high demand. It keeps the payment for people who enter those fields very high. All those things are advantageous to the medical profession as a whole in terms of retaining its prestige and its stature, right? If all of a sudden we start producing, thousands more of this rare specialty doctor or that rare specialty doctor, you would probably find salaries go down for that field. You would probably find the best and brightest maybe not going into it as much, or people would say that. And so there's definitely the structures that educate and train our workers are also ones that have to be dealt with in terms of how to get them, incentivize them to produce more of the people that they're turning out.
Now, this is something that just occurred to me. Perhaps you wanted to comment on that. Medical tourism, is that a way to alleviate these shortages where patients go to other countries where there are doctors maybe in greater supply?
I think it is for probably more affluent, families or people with the means to do that. I mean, even though care may be cheaper for certain, and that's really more for specialty or surgical type procedures. Yeah. When you talk about basic primary care prevention, that kind of model doesn't exist. People wouldn't go to another country just to get primary care. Yes. But they might go to get, a surgery that might cost, 5 times more in the United States. They might go somewhere else to do it. But even that has its limits. It's even if everybody here in the United States wanted to go, to India or another country to get a surgery, those countries would very quickly find their resources strained as well.
Right. Tim, you've talked, I think, in your own writing about the aging workforce. And this is a global phenomenon from what I understand in the US, in Japan, China, Europe, etc. So what is your take on aging as an environmental occurrence that's going to have a long-term impact on healthcare?
Yeah, this is probably the most significant demographic trend that's going to affect, in every country, the cost of healthcare, the need to create more capacity to deliver healthcare. Most of the cost of healthcare is spent in a person's last few years of their life. Okay, so, as we've lengthened lifespans, which again has been a good thing, right, in many countries, people are living longer, which means they're developing more chronic diseases, more illnesses that have to be treated. And we're able to treat people in a way that they can live with those illnesses for a long time. But again, that adds cost to the system. That adds a need for those people to access the system. And so this is going to have to be dealt with by every country. And it won't be able to be dealt with the current way we think about and deliver healthcare now. There simply is not enough capacity in any system. So we're going to have to really invent and innovate in a way that we haven't before in order to meet even just the basic needs of, for example, individuals between the ages of 70 and 90 or 70 and 100 who, will demand and need more healthcare resources. And I'm not sure any country's healthcare system has really owned up to the reality of what this issue is going to mean for healthcare policy and also the investments that countries are going to have to make in their health systems.
I've seen in numerous news reports saying that the elderly want to age in place. And you've written about the trend to healthcare delivery at the home. So is this a trend that will intersect with this aging population's desire for aging in place rather than going into a nursing home?
Yes, I think. Look, who doesn't want to get their health care at home if they can avoid going to like a hospital setting, right? That creates anxiety. Things can happen when you go into a healthcare facility. You can contract an infection, right? So this idea, it's convenient. And I think one of the first places you're going to see this moving health home movement is in the senior, care sector, because it makes a lot of sense. Many older individuals, for example, I say this to my class, say, what's the number one, threat to a senior person? It's falling. And so if you can limit, for example, the amount of times that someone who's older has to leave their home to go to a healthcare facility or a doctor and deliver care in the home, you're actually providing a safer environment for them, as well as delivering care to them, in an environment that they're going to be much more comfortable with. So I do think this will be where they call it the moving health home effort is going to really focus on first, and I think there's going to be a very large market, at least in the U.S., for it.
Now, your most recent book is called Searching for the Family Doctor. Right? It's a nice title, I think. It's intriguing and immediately makes you want to think, what's this book about? Maybe I should pick it up and start browsing it. So what is the book about, and why did you write it, and what are the central themes?
Yeah, the book is sort of it's the third book in sort of I say that I didn't realize I was writing a trilogy, but it ends up being a trilogy.
Right.
And this book is really about, and all the books are about primary care transformation, about how the system in the United States is transforming and how it's going to continue to transform for all the reasons we've been discussing. This particular book was just simply about the specialty of family medicine, the medical specialty, which produces the doctors that go into the primary care system, and how they're sort of disappearing from the scene. Fewer medical students choose to go into primary care careers for reasons, it pays less, it's hard work, it's viewed somewhat differently than other medical specialties. And so the book was really about looking at, well, we're at this seminal moment where we have this group of doctors that are sort of integral to this huge part of our healthcare system, primary care. There's less and less of them, and more of them, and I study this in the book, more of them are choosing to pursue their careers in ways that are different from maybe what the primary care system needs. And so it was really looking at, if we're moving from a physician-centric primary care system to a different kind, how is that going to start to look over the next 10 years?
And so what are the conclusions you've come to?
Well, for family doctors, the conclusions aren't necessarily uplifting. I think we're going to continue to see a decrease, not just here, but all around the globe, in doctors going into sort of primary care. So that means that what they used to do is going to be what they used to do is going to have its place taken by other sorts of innovations. So what I see is definitely more digital health coming onto the scene that will actually do more primary care for people. Artificial intelligence is an area where AI may slide right in and help the doctor do some of their work, but also possibly replace some of what the doctor, who's no longer there as much, also does. And I also think it means something transformative for our expectations about primary care. My son who's growing up, may not ever think that he needs or wants a primary care doctor, because the system, by the time he's an adult, may not have a doctor as the central piece of it.
I'm glad you brought up AI, because that's something that I think about occasionally. Well, everybody who's an academic or a manager has to think about AI. So broadly speaking, is AI a transformative influence on healthcare?
I would say not yet. Probably that's true for many industries. But to think that it won't be is probably naive thinking. I definitely think it will be a transformative factor. It will change the way a lot of patient care is done. It will change the way, as we discussed, people like doctors work. And it will change the way we do work in key areas like primary care. Will that take another decade or another 20 years to really be realized? Maybe. But we're already seeing right now some of the ways artificial intelligence can be used. For example, right now it's focused mainly on the administrative aspects of, for example, doctors' work. So virtual scribes. A doctor goes into a room now. They used to have to take their own notes, or they used to have a person taking those notes. Now natural language processing algorithms can actually record everything, transcribe it, and put it right into the electronic health record. That's good potentially, because that relieves doctors' workload. And to the extent AI is used to help the doctor out of doing work they don't want to do, I think doctors are okay with it. It's when it starts to move into where it's helping and doing diagnosis and treatment, that's where I think we'll really see the tensions emerge between the human element and the machine element. But I still think we're several years away from that sort of thing becoming widespread.
Yeah, I remember seeing a study, summary of a study, I should say, talking about using AI to look at images of cardiograms, and found that AI was almost as good as the doctor in terms of being able to detect anomalies where some intervention or some additional probing was needed. So when I saw that study, I thought, well, that could be very useful to doctors who have huge number of cardiograms to look at, and this makes it possible to get to patients quicker. So it could be a positive, but at the same time, if that's one of your main sources of revenue as a doctor, the time you take to read a cardiogram, then maybe that has some implications for, is AI going to take my job or make my job less valuable? But another issue that I think is relevant is the whole issue of data privacy. In the US, we have HIPAA, and I'm sure from your experience in the UK, you have similar privacy issues in the UK, and I know we have them in India and elsewhere. So AI requires data. So how is that going to be reconciled? The need for AI to be able to get huge amounts of data about patients and about interactions of drugs and about doctor-patient, you mentioned medical records being transcribed, and I assume they could be then read by the AI across all patients. So how would this play out, you think?
It's definitely a reality, and it's a reality that's not going to go away. I mean, as you said, AI, the most powerful algorithms, the most effective and accurate algorithms, right, rely on the biggest, largest, and most accurate data sets. And those data sets are going to contain information on patients. They're going to contain information on patient conditions, how much patients are paying for care, what's working with them. And so, you already see this. We have chronic disease management programs. We have different kinds of things that are segmented to help certain groups of patients, and they're already being driven by sort of AI. But the issue of privacy looms large. Even if you de-identify this information, for example, there's ways you can still reconstruct it at another level to identify whose information it is. And so this will have to be dealt with. I don't think HIPAA is going to be the kind of, regulation that's going to be able to deal with it, nor is the FDA, who, the Federal Drug Administration, which regulates, for example, medical apps and technology. There's going to be a lot more policy that's needed. But there's no doubt that we are probably going to have some problems and some issues before it gets better. People's data being, compromised, leaked, hacked.
Yeah, I think hacking is a real fear these days. Recently, United Health, their records were hacked, and there was a fairly serious interruption to payments. Providers were not getting paid. So, given all these years of research and your deep knowledge, what are some broad lessons that you would kind of offer our audience, both executives in the healthcare industry as well as policymakers? And I'm guessing this would be valid not just for the U.S., but for healthcare professionals and policymakers in other countries also.
Yeah, I think, one of the big lessons is, no matter what country we're talking about and who pays for the healthcare, whether it's a single-payer government system or it's a system like the U.S. where you have, private insurance, employer insurance, government funding healthcare, it's a business. And we need to approach it in some ways as a business. What I mean by that is in the best nature of the word, which means thinking about how to create, workflows and services and products that are user-centric, that meet the value propositions of really who the customers are, and those are the patients. And most systems have not thought that way. Most systems have thought more in this paternalistic, hey, here's what we're going to fund and provide to people, and you're going to love it, and really don't ask for anything more because this is what the system can give you. But I think moving forward, the big lesson is, like other industries, we need to transform to a more, patient as consumer-centric system. And that means, really thinking about things like value from the patient's eyes, thinking about things like cost-quality trade-off. Mm-hmm. And so, I think the organizations that start to think more like that and then innovate along those lines to deliver on those value propositions for the patients, I think those will be the ones that will find they'll be, able to deal with some of these big problems that are coming more effectively.
Mm-hmm. This has been a really fun conversation. Thank you very much, Tim.
Sure, thank you.
And I hope our audience benefits from your vision of how the healthcare system is changing and what it means for delivery. I think there are a lot of ideas that our audience can act on to change healthcare for the better. So thank you. And if you have enjoyed this episode, please do subscribe to our International Business Today podcast series. We've released around 30 episodes, and we have new episodes constantly being recorded and released regularly. So I hope you'll continue watching. And, of course, we are happy to receive your comments and suggestions. This is Professor Sarathi and my guest, Professor Timothy Hoff. Thank you for listening to us, and see you again soon on another podcast.